Dr. Satyaveer Singh for the presentation.
Thank you, sir. And good morning to all. Dr. Satyaveer, please share and start your presentation.
Yes, sir. Good morning to all. Today I am going to present a seminar on topic renovascular hypertension and ischemic nephropathy. Moderator for this session is Dr. Sahu, sir. Now, coming to the definition of the renovascular hypertension, it is a clinical syndrome marked by the rise in the arterial pressure with or without associated ischemic or hypertensive renal injury, where maybe partial or complete occlusion of one or both renal arteries, they result in renal ischemia, and as a result, lastly, renovascular hypertension develop. Renovascular hypertension, it is the most common form of secondary and potentially curable hypertension. And coming to the definition of ischemic nephropathy, when there is a reduction in the renal perfusion resulting from the atherosclerotic renal artery disease, that leads to the renal parenchymal loss or ultimately declining renal function. This condition is characterized or known as ischemic nephropathy. Now, coming to the incidence in etiology, the renovascular hypertension affects almost 5% of all hypertensive people, comprises of 10 to 20% of end-stage renal disease population and 5 to 15% of renal failure population having age more than 50 years. It is the most common cause for this is renal artery stenosis, and renal artery stenosis is defined when there is a luminal narrowing greater than 50%. This renal artery stenosis can be related. There are two major factors have been described. Number one is atherosclerotic renal artery stenosis that comprises 60 to 80%, and remaining 20 to 40% cases belong to fibromuscular dysplasia. Other rare causes, they are arterial aneurysm, arterial malformation, extensive renal artery compression, and neurofibromatosis type 1. Coming to pathology, there are two major pathological entities. Number one is atherosclerosis and two is fibrous dysplasia. Coming to atherosclerotic renal artery disease, predominantly affects men and women aged 40 to 70 years. The proximal third of the renal artery mainly is involved. In 70 to 80% cases, there is a aortic plaque present on the renal ostium, and remaining 20 to 30% cases, they show non-ostial narrowing, generally 1 to 3 centimeter distal to the renal artery ostium. Coming to the fibrous dysplasia, it is a non-atherosclerotic, non-inflammatory vascular disorder. Multiple subtypes have been described on the basis of in which layer the calcification or fibrosis is present of the vessel wall. The majority of cases affect the tunica media, so the medial fibroplasia is the most common type. The less common type are perimedial fibroplasia, intimal fibroplasia, and medial hyperplasia. The incidence or frequency of medial hyperplasia is 70 to 85%, and perimedial fibroplasia comprises 10 to 25%. Remaining 10% belong to intimal fibroplasia. The risk of progression will treat to renal function. It is more in the intimal fibroplasia and perimedial fibroplasia, while medial fibroplasia it is generally less progressive and there is minimal threat to the renal function. By description, medial fibroplasia, the medial it means the tunica comprises fiber in the ring forms, and the distal half of the renal artery involved. Sometimes certain branches are also involved. And the typical pattern on the angiography is a string of bead appearance because of arterial stenosis and post-stenotic dilatation. It's generally seen in women, they are 30s and 40s, and it is a non-progressive disease. Collagen fiber deposition in surrounding the tunica media, or it is beneath the adventitial layer. Generally seen in young women 5 to 15 years of age, also called as Gurley disease. In this, there is a tightly stenotic lesion and extensive collateral circulation on angiography are present. This involved mainly mid-renal artery. Intimal fibroplasia, in this only tunica intima has collagen fiber deposition or mainly proximal, and it is progressive fraction disease. It is only comprised of outer smooth muscle hyperplasia of the tunica media, and angiographically there is smooth renal artery stenosis or its branch. Before coming to the pathology, we will have a look over a renin angiotensin activating system. When there is renal artery stenosis, there is decrease from blood flow to the renal artery and decreased GFR lead to the stimulation of the renin hormone from the GG apparatus. It converts angiotensin enzyme into angiotensin substance into angiotensin first. Angiotensinogen, it is present in the circulating in the plasma produced by the liver, and angiotensin first is converted to angiotensin second by the angiotensin converting enzyme. This is enzyme that is produced by the lung parenchyma. So this angiotensin second is a main substance that is responsible for this hypertension. It is mainly vasoconstrictor agent and is also responsible for aldosterone secretion. Sometimes myocardial effect or vascular effect or sympathetic nervous system stimulation is because of this angiotensin second. Now, proper pathophysiology of renovascular hypertension. In Goldblatt and colleague, they perform experiment on the dogs, and they for knowing that renal ischemia is the enzymatic event in the development of renovascular hypertension or not. On the basis of this experiment, two models were proposed. 2 kidney 1 clip model, that is also called as vasoconstrictor hypertension model, and 1 kidney 1 clip model, that is also called as volume hypertension model. The pathophysiology of both the models are different. Coming to the 2 kidney 1 clip model, it resembles generally human renovascular hypertension model because when one kidney is clipped, it means one kidney renal artery stenosis is present and contracted, which means normal. This renal artery kidney is clipped, there is a decreased blood flow to the renal artery, decreased blood flow to the renal kidney lead to the decreased GFR. Ultimately, previously described on the help of the renin system, angiotensin second is produced. Angiotensin second causes generalized vasoconstriction and systemic hypertension. But here contracted kidney is normal, so contracted kidney experience higher perfusion pressure than the normal. So there is renin secretion decrease in this contracted kidney. As a result of it, there is sodium and water excretion. So pressure net reduces there. So the treatment for this mainly unclip the kidney. It means give the AC inhibitors or ARBS. In this but there is one kidney one clip model. In this one renal artery is clipped, it means one renal artery stenosis and another renal artery. If it is then one or is bilateral stenosis, it is also applicable on this model. The renin angiotensin or causes generalized hypertension and general vasoconstriction and hypertension. But here there is no contralateral kidney, that is normal. So there is no pressure and no pressure water net basis. So volume expansion is present here. So edema is present in the person. So here AC inhibitor and ARBs are not useful in this type of treatment. Generally we give diuretic or furosemide for this type of treatment. When in this both the kidney have normal or decreased renal hormone, but peripheral in plasma there is increased renin hormone. Now pathophysiology of ischemic nephropathy. When there is a chronic hypoperfusion of the total renal functioning mass as bilateral renal stenosis or stenosis functionally or anatomically in solitary kidney, there is a critical reduction of the renal blood flow that lead to the formation of the angiotensin second. Here this angiotensin second cause efferent arterial constriction to try to maintain the GFR, or ultimately when condition persists for a long time, there is redistribution of flow in the kidney itself. There is a decreased flow to the cortex and to prevent the medullary anoxia. If there is reduced renal blood flow, it is reduced cortical perfusion, reduced GFR or activation of the system. This causes cortical oxidation. Later phase is type of develop that lead to the vascular rear fracture. Lost oxygen stress is developed. So oxidative stress injury leads to the ischemia and hyperfusion injury. Ultimately, inflammatory cell infiltration occurs. There is so much release of the cytokines, pro-inflammatory that lead to the ultimately fibrosis, glomerulosclerosis, or that lead to the end-stage injury or referred kidney. The most present or only small percentage present with the mild or mild hypertension or normotensive, and 10 to 14% cases may go to the malignant or accelerated hypertension, or similar prevalence in the Caucasian and European, African and American female population. Certain clinical criteria, if they are present, we should prompt to evaluate for arterial renal atherosclerotic renal artery stenosis. If there is hypertension, years of age, if accelerated hypertension, severe hypertension present, hypertension, if resistant to optimal medical therapy, or there is asymmetrical kidney size. If kidney size, both the kidney size have difference more than 5 centimeter in the craniocaudal length, or of the kidney function, or recurrent or rapid decline in GFR, or decline in GFR after analysis of ACMR or angiotensin receptor blockers. One additional thing is, of all children with unexplained hypertension, this will be screened for renal artery stenosis. Other clinical features are advanced age of clinical feature or risk factor for atherosclerotic disease like hypertension, chronic kidney disease, hyperlipidemia, diabetes mellitus, tobacco exposure, and history of atherosclerotic disease, previous history of atherosclerotic disease in coronary, cerebral, and peripheral artery circulation. Extremity, lower extremity pulse, peripheral edema, or abdominal bleed. Coming to the classification by the Heart Association, in all the third class stenosis is present, but in grade first there is no clinical manifestation. So the patient is have normal renal function and patient is normotensive. In grade second, along with the stenosis, they have a medically controlled hypertension, but functions are normal. But in grade third, abnormal, refractory, medical refractory hypertension, or there is evidence of volume overload. Now, some specific feature of clinical feature of fibromuscular dysplasia. The diagnosis of this renal artery fibromuscular dysplasia, mainly when we are investigating an asymptomatic patient for any other abdominal imaging, we find this disease. The most commonly affected population in Middle East women with new onset or difficult to treat, difficult to control hypertension. Other feature may be flank pain or hematuria. Hematuria may be because of aneurysm rupture or maybe atriovenous malformation. First are intravenous measurements scintigraphy. But the non-invasive is used with high sensitivity, magnetic and computed tomography scan, and duplex ultrasonography, duplex Doppler ultrasonography. Coming to one by one, duplex ultrasonography is a screening test of choice. There is altered flow pattern distal to the stenotic lesion, or in the systole phase there is turbulent jet, and in diastolic phase there is decreased flow. Peak systolic velocity is generally greater than 180 centimeter per second, and normal value is 100 plus minus 25 centimeter per second, and resistive index is generally more than 0.7, and renal aortic ratio, that is described by the peak systolic velocity in renal artery divided by the peak systolic velocity in specialty, generally more than 80%. And advantage is generally it is non-invasive method. Any material in this, there is no need of any stoppage of certain medications prior to this investigation. So no allergic reaction, no contrast. Disadvantages, generally it is highly operator dependent, as ultrasonography is. Or sometimes in obese patient, we will find difficult to find renal arteries, or if extensive bowel shadow is present, bowel gas is present, or sometimes small accessory renal artery may be missed on this scan also. Coming to magnetic resonance angiography, the sensitivity for renal artery stenosis is greater than 90%, but it has very sensitivity for segmental stenosis. Sometimes very few segmental fine segmental artery may be missed. If a patient has GFR less than 30 ml per minute, then gadolinium-induced nephrotic systemic fibrosis may be there. This shows right renal artery stenosis MR angiogram. CT angio, in this thin slice, almost 2 millimeter slices, they are taken over when we are in arterial phase, when we are injecting the contrast. Sensitivity specificity generally 96 and 99%. If the same greater than 1.7, the risk of nephropathy and nephrotoxicity increases. The advantage is that aorta and main renal artery can be visualized, but renal morphology or parenchymal lesion, they are also seen. The disadvantage is distal to the main stem renal artery, they are difficult to define. Contrast angiography. There is a gold standard for diagnostic renal artery disease. The intra-arterial digital subtraction angiography is the gold standard. Usually done in a part of combined and diagnostic and therapeutic procedure, but not suited for screening purpose. We use this when we are suspecting strongly. If it is expensive technique and require arterial puncture, arterial catheter introduction, ionized retin also may be used, and injection of ideal contrast material is given in this. Digital subduction angiography, in this contrast load is decreased and catheter size is also decreased. This 83-year-old mildly hypertensive patient so left renal artery only a step, complete occlusion. Overall, if there is clinical feature of hypertension, we should confirm with that contrast angiography. Initially, for a screening test, we should use CT angio, MR angio, duplex in suspicious cases before going to the contrast angio. Some rare cases we may have functional imaging. Additional imaging, we have radionuclide radiography and plasma renin determination. Radionuclide radiography may be done by the DTP scan or MAG3 scan. Generally, at present, no use. Only use when we are planning nephrectomy and want to get differential renal function. Sometimes captoperitoneal renography or captoperitoneal test also done, but nowadays it's not used. Currently, the limitation is a well-serum creatinine greater than 2, and bilateral disease, then there are low sensitivity of this radionuclide radiography. Plasma renin determination is maybe the diagnostic. In this, determination of the renal level from the renal vein sample is done, but limitation is that for this some concurrent medications they must be addressed. Blood pressure must be tightly controlled, adequate hydration should be present. Or the main limitation is that initially renal hormone is elevated and later on it declines. So and endovascular, it means percutaneous transluminal renal angioplasty, abdominal stenting or surgery, have revascularization and nephrectomy option. Indication of the medical management: when there is well controlled hypertension and the hypertension is then we will go for then we should go for medical management. Or if there is a poor threat to the renal function, so we can continue medical management. The option for medical therapy are: first line choice is the AC inhibitors and angiotensin receptor blockers. We advise to combine diuretics and blockers. Also, so target LDH cholesterol should be less than 100. Strict management of diabetes. Antiplatelet agent aspirin should be started, and certain lifestyle modifications should be done. Likewise, smoking cessation. Management of the complication of the renal insufficiency, like anemia and hyperparathyroidism, should be addressed. Now, selection of the patient, criteria for selection of the patient for any intervention. If hypertension, that is not responsible to multimodal medical therapy. If a patient taking a AC inhibitor or angiotensin receptor blocker and there is decreased GFR or elevation of the creatinine, and if refractory or recurrent congestive heart failure is present, on renal biopsy, there is favorable renal biopsy, it means there are salvageable glomeruli, there is no glomerulosclerosis, and creatinine concentration is less than 4, and evidence of collateral circulation are present, renal size is greater than 9 centimeter, and positive nuclear function study, then we should go for any and the patient is asymptomatic or hypotensive, then follow up for the patient up to development of hypertension. Young, otherwise healthy patient, they are diagnosed proximate to the onset of hypertension, we should go for percutaneous transluminal renal angioplasty. Medial fibroplasia, medical management is done, surgical management done when BP is not controlled by multiple drugs, or in intimal or perimedial fibroplasia. Early intervention or angioplasty is the initial treatment because it is both are progressive disease and ultimately end up in renal failure. So we should go for angioplasty in the initial treatment. Now, Doppler ultrasound based surveillance of the kidney length and cortical thickness should be done once or twice per year in the cases of fibromuscular dysplasia. If it is not successful, then we should go for branch chain disease. We should go for atherosclerotic hypertension. In this vigorous medical therapy with multiple drug regime should be started. With stable renal function, BP is controlled and stable renal function is and if successful observe the patient, if technically angiography not possible or any reason angioplasty is not possible, then we should consider surgical intervention. Now, certain clinical clue that denotes the renal salvageability. They are, if there is an angiographic demonstration of the retrograde filling of the distal renal artery by the collateral vessels on the side of the total arterial occlusion, or renal biopsy so well perfused glomeruli, kidney size if greater than 9 cm, or function of the involved kidney on isotope renography or IVP. When such criteria are present, renal, we should not go for nephrectomy, we should salvage the kidney. Now, the indicated lesion is less than 1 cm in length, it is partially occluded, or lesion doesn't involve the ostium, then patient have a hemodynamically significant renal artery stenosis, accelerated or malignant hypertension. When they are hypertension with unexplained unilateral small kidney or hypertension with intolerance to medication, we should go for PTR, angioplasty. The complications of angioplasty are certain extended complications of angiography like puncture related to the arterial puncture, maybe hematoma, puncture site hematoma, bleeding, or usually hydrated contrast material, maybe allergy, maybe contrast to nephropathy. Now, specific complication, they are the development of the reversible acute renal failure, or thrombosis, perforation, dissection of the renal artery, or diffuse atherosclerosis, maybe transient deterioration of the renal function. It is the most frequently occurring complication as a result of angioplasty. Angioplasty in fibrous dysplasia. It is primary modality treatment performed without stent placement at technical success rate greater than 90%. In this right renal artery, so medial hyperplasia in the stenosis of main renal artery, and after angioplasty, there is a caliber of the we are looking at caliber of the renal artery is again reachieved, so there is no stenosis. Now, angioplasty in atherosclerotic renal artery stenosis. Generally, it is less successful and more morbid because this disease is generally bilateral and involve the ostium. So, also there is a scope atheroembolism. So, generally, we should go at angioplasty in atherosclerotic disease when we are only preserving the kidney or we want to improve the renal function. Endovascular stenting. The indication of stenting are when there is poor immediate result during angioplasty, restenosis after angioplasty, and when a complication of angioplasty develops like artery section and intimal flaps. Renal artery stents, they are adjunct to angioplasty. Better results are generally observed when angioplasty and stenting both done, PTRS, especially in the osteoartery. Radio opaque, they are form of the expandable metallic wire mesh tube and widely used in the peripheral vascular system. Success rate is greater than 95%, but restenosis rate is 6 to 38%. In this, there is iotography, so high grade renal artery stenosis from osteoarterial plate. After stenting, there is relief of the renal artery, left renal artery stenosis. Coming to the surgical revascularization. Main goal of surgical revascularization is repair of the renal artery disease by this vascularization. Indication are if there is concomitant aneurysm or occlusive aortic disease, if mechanism of renal artery stenosis, pregnant or accelerated hypertension who didn't respond or can't tolerate medical therapy, or angioplasty when technically not feasible, we should go for surgical revascularization. Pre-requisite for surgical revascularization, they are if kidney size is greater than 8 cm in length, there is distal cutoff, it means a distributed filling of the distal renal artery by the collateral vessels on radiographic imaging, and distal renal artery is patent, and the involved kidney is viable on isotope stent, or there is minimal glomerulus or healthy glomerulus with well-preserved tubule on renal biopsy. Operative techniques. If there is healthy abdominal aorta, we should go for aortorenal bypass with a free graft or autogenous graft. The options are hypogastric artery, or we may use saphenous vein. If autogenous graft is not available, we should go for Moderator fluoroethylene PTFE graft. But when abdominal aorta is not healthy, then we should go for alternate bypass technique. If we want to left renal artery revascularization, go for splenorenal bypass. For right renal artery revascularization, go for hepatorenal bypass. Sometimes renal bypass also done. Sometimes vein surgery with auto transplantation may be the option while using supraciliac and lower thoracic arteries. This is splenorenal anastomosis, and in this hepatic artery anastomosis the renal artery by using the great saphenous vein graft. And this result. If the disease is cured, when we say disease is cured, if the blood pressure is 140/90, or less postoperatively. We would call improved if there is reduction in diastolic pressure of 10 to 15 mg or more, or patient become normotensive on medications. But result are fewer patients are cured and more patients are improved. It means cure rate is less and improvement is more. But now secondary renal revascularization. When we have already done surgical revascularization or angioplasty, then again stenosis developed. So we should go for secondary renal revascularization. It is generally postoperatively, and options may be repeat angioplasty may be done, or surgical revascularization may be option. Now, for nephrectomy small kidney, its liver function. Patient having severe arterial severe uncorrectable or renal infection is there. Now, the medical management of the renovascular hypertension, it is preferred when they had hypertension or there is significant comorbidity, patient is not fit for any intervention. The aim of to overall risk of the cardiovascular morbidity, just not to the lower the BP. Minimum treatment by the angioplasty. Without the stenting, it is preferred method for treating severe hypertension or ischemic nephropathy. Angioplasty is generally successful in the fibromuscular dysplasia or atherosclerotic disease. Generally require an angioplasty with stenting. It means PTRS. Thank you.
Thank you, Dr. Satyaveer, for kind of elaborate presentation on renovascular hypertension. And thanks, Dr. R.D. Sahu, for moderating. I will seek apologies for the sound, probably, which was not as good. So we would try to make it as clear as possible in the next class. So before that, if we have any queries from the students or any member who have joined us on Zoom, so let me know that so that we can just discuss it out. If you do not have any query now, so what I will just give you a brief summary about renovascular hypertension. We all know hypertension is such a common problem affecting millions of people around the world. And around, we would say 10% of the cases are secondary hypertension, and rest of them are primary hypertension or the essential hypertension. And of the secondary hypertension, renovascular hypertension is one of the most common causes, and it accounts for almost 75% cases of secondary hypertension. And we would suspect a secondary hypertension always in a patient who needs two or more than two medications for hypertension, and still maybe it remains uncontrolled. And sometimes it requires a diuretic therapy also. And particularly in patients, premenopausal females who has hypertension, we need to rule out secondary hypertension due to renal artery stenosis because of fibromuscular dysplasia. So most of these hypertension would result in resistant hypertension, and they may cause problems like ischemic nephropathy and may cause even uremic symptoms. So it's very important to diagnose this condition and treat this condition. And we all know that the diagnosis, the main hallmark is a history and a physical examination, which might show an abdominal bruit on auscultation. And then we need to investigate further. And in majority, the screening test would be, the ideal test would be a duplex ultrasound Doppler study, which can tell you that this patient may have a renal artery stenosis. And the confirmation before any therapy has to be done by the gold standard test of renal angiography. We have other tests like CT angiography and MR angiography, which also may be helpful in these cases. And plasma renin activity is also one of the ways by which can suggest us this is a case of renovascular hypertension. And previously, we used to do quite often captopril renal scan, which is not often done nowadays. And renal scan would be often only done when we need to know the differential function before going for nephrectomy in these patients. So, so once we diagnose this case, definitely the treatment would depend upon either medical or surgical management. Mild cases can be dealt with medical management, and the patients who are resistant to medical therapy would require surgical management, as Dr. Satyaveer has already elaborated on, which includes angioplasty with or without stenting, and maybe sometimes a revascularization, and sometimes may require nephrectomy. So thank you all, everybody, all the residents, faculty members. Now I would ask Dr. R.D. Sahu if he has any comment to make, and if any query from any of the members, please go ahead, Dr. Sahu.
Thank you, sir.
So if we do not have any kind of query or comments from any of the members, are you finding any of the member who is having any comment? Because I'm not able to see all the participants. So if you are able to see, just try to invite him. Otherwise, we will conclude this session with a vote of thanks from yourself.
Yes. There is no comment or query from
okay. Fine. So just give your vote of thanks, and then we will conclude the session. Yes.
But thank you for all viewers for joining us. Thank you.
Thank you. Thank you once again, Dr. R.D. For moderating the session, Dr. Satyaveer for presenting this session, and all the residents and faculty and all other members who might have joined us today on Zoom. Thank you very much, and have a great day. Thanks.